Hey everyone, if you are studying for the NCLEX and want to stay ahead with the most important topics, you are in the right place. Today's video, titled Pharmacology of Respiratory, will cover the must-know medications used in asthma, chronic obstructive pulmonary disease, respiratory distress, and airway infections. From bronchodilators and anticholinergics to corticosteroids and mucolytics, we are breaking it all down. We will go through 15 high-yield NCLEX-style questions, each with clear, detailed explanations to help you understand not just the answer, but the reasoning behind it. These are exactly the kinds of questions that may show up on your exam. We release new NCLEX-focused videos every day, so make sure to subscribe and follow if you want daily practice, tips, and explanations to boost your exam success. Let us jump right in. Before we dive into today's question, let me ask, are you completely prepared for the NCLEX? If there's even a bit of hesitation, our Complete NCLEX Review online course has your back. You'll get access to 100 hours of animated content, 500 hours of in-depth lectures, 5,000 high-yield questions, 500 NGN-style case studies, and 15 mock exams designed to feel like the real thing. You'll also receive a comprehensive NCLEX ebook, all valid for 1 full year. Right now, you can grab it at 70% off for a limited time. Thousands of students are already on the path to success, and you can be too. Click the link in the description and get started. All right, time to dive into the next must-know NCLEX topic with a clinical judgment question that puts your medication safety skills to the test. And now, let's bring on the question number 1. A nurse is reviewing new medication prescriptions for a group of hospitalized clients. Which order should the nurse question due to an immediate risk of worsening the client's current clinical condition? Now, take a moment and consider your options carefully. All right, let's go over the answer choices. Option A, Albuterol nebulization for a client with a serum potassium level of 3.0 milliequivalents per liter. Option B, warfarin for a client with newly diagnosed atrial fibrillation. Option C, metformin for a client with type 2 diabetes mellitus and stable chronic kidney disease. Option D, pantoprazole for a client receiving long-term non-steroidal anti-inflammatory therapy. Let us analyze these options one by one and uncover which prescription puts the client at the greatest immediate risk. The correct answer here is option A, albuterol nebulization for a client with a serum potassium level of 3.0 milliequivalents per liter. Now, let me explain why this answer stands out, and more importantly, why it matters so much in clinical practice. Albuterol is a beta-2 adrenergic agonist that is commonly used to open the airways in conditions like asthma or chronic obstructive pulmonary disease. But here's the catch. Albuterol also causes potassium to shift from the bloodstream into the cells. So if a client already has a low potassium level, like in this case where it is just 3.0 milliequivalents per liter, albuterol can push that potassium even lower. And that is dangerous because hypokalemia increases the risk of life-threatening cardiac arrhythmias, including premature ventricular contractions, torsades de pointes, and even ventricular fibrillation. That is why this order must be questioned right away unless the potassium level is corrected or very closely monitored during administration. Now let's quickly rule out the other options so you can see why they are safe in this context. Option B, warfarin is appropriate for a client with newly diagnosed atrial fibrillation. This medication helps prevent blood clots and reduces the risk of stroke, which is a major concern in atrial fibrillation. As long as the client does not have active bleeding or a contraindication like severe liver disease, warfarin is an appropriate and effective choice. Option C, metformin is a first-line medication for type 2 diabetes mellitus. While it should be used cautiously in chronic kidney disease, it is not contraindicated if the client's estimated glomerular filtration rate is above 30 milliliters per minute. As long as kidney function is stable and regularly monitored, this medication can safely help control blood sugar levels. Option D, pantoprazole, is a proton pump inhibitor used to protect the stomach lining, especially in clients receiving long-term non-steroidal anti-inflammatory medications. It prevents ulcers and gastrointestinal bleeding, making it a beneficial prescription in this setting. So, once again, option A is the correct answer, and it highlights a classic NCLEX theme, recognizing when a common medication may become harmful based on the client's current lab values or condition. These are the kinds of safety-focused decisions you will make every day as a nurse, and they are exactly what the NCLEX wants to see you understand. Stay with me as we move into the next high-yield scenario. Let us keep the momentum going with another high-yield NCLEX scenario that dives into client education and safe medication practices. Get ready. Here comes your next challenge. Question number 2. A client presents to the outpatient clinic reporting that their nasal congestion has worsened, despite daily use of an over-the-counter nasal decongestant spray for the past 10 days. The client denies signs of infection or allergy. Which instruction should the nurse prioritize in this scenario? Take a moment and consider each option carefully, as this is a classic case of medication overuse leading to unintended consequences. Now, let's break down the available options. Option A. Increase oral fluids and continue the nasal spray until symptoms resolve. Option B. Use the decongestant only at bedtime to minimize daily use. Option C. Stop the decongestant immediately and allow the nasal mucosa to recover. Option D. Add warm saline rinses while continuing the spray to enhance clearance. Let us break this down and determine the safest and most effective instruction for the nurse to prioritize. The correct answer here is option C. Stop the decongestant immediately and allow the nasal mucosa to recover. Now, here is why this response is so important. The client is experiencing a condition called rhinitis medicamentosa, also known as rebound congestion. This occurs when intranasal sympathomimetic medications like oxymetazoline or phenylephrine are used for more than 3 to 5 consecutive days. These medications initially work by causing vasoconstriction, reducing swelling in the nasal passages. But with continued use, the nasal blood vessels become less responsive, leading to rebound vasodilation, mucosal edema, and worsening congestion. Exactly what this client is reporting. The only effective intervention is to stop the medication entirely, so the nasal tissues can heal and regain normal responsiveness. Symptoms might get worse briefly after stopping the spray, but they usually improve within 1 to 2 weeks. Option A. Increasing fluids is generally helpful for thinning mucus, but it will not resolve the cycle of rebound congestion if the spray is continued. Option B. Using the decongestant only at night may reduce the total daily exposure, but does not eliminate the underlying pathophysiology. The damage continues as long as the spray is used. Option D. Warm saline rinses may help with temporary symptom relief. But again, the issue is not drainage. It is drug-induced inflammation. Continuing the spray will override any benefit the saline may provide. So, there you have it. This scenario really drives home an important message. Even something as simple as an over-the-counter nasal spray can cause harm if it is not used correctly. It is easy to assume these medications are harmless because they are available without a prescription, but as nurses, we have to look deeper. This is where client teaching becomes crucial. We are not just giving care, we are also guiding our clients to use medications safely and effectively. And when it comes to nasal decongestants, that 3 to 5 day rule is non-negotiable. Beyond that window, you are not helping the problem. You are feeding it. We are not done yet. Let us shift our focus now to pediatric respiratory emergencies. This next NCLEX question zeroes in on recognizing and managing acute airway distress in children, which is a critical skill every nurse must master. All right, it is time for the question number 3. A pediatric client with a confirmed diagnosis of laryngotracheobronchitis, also known as Croup, is exhibiting worsening inspiratory stridor at rest, increased work of breathing, and an oxygen saturation of 92% on room air. The nurse should anticipate obtaining a prescription for which intervention to address the client's current respiratory distress. Take a moment to process the key symptoms in this case. And now, let us explore the possible interventions. Let's take a closer look at what we are working with. Option A. Inhaled tiotropium via HandiHaler. Option B. Oral loratadine once daily. Option C. Intravenous aminophylline infusion. Option D. Nebulized racemic epinephrine administration. Let us evaluate these choices to determine which one is most appropriate for this child's acute condition. The correct answer here is option D, nebulized racemic epinephrine administration. This is the go-to treatment in moderate to severe cases of Croup where the child is showing signs of upper airway obstruction, such as stridor at rest and low oxygen saturation. Racemic epinephrine works by constricting the swollen subglottic blood vessels, reducing airway edema, and allowing for rapid improvement in breathing. The effects can be seen within minutes, stridor decreases, oxygen levels improve, and respiratory effort becomes less labored. However, it is important to know that the relief may be temporary, so the child must be monitored closely for any return of symptoms. Option A is incorrect because Tiotropium is a long-acting bronchodilator used in chronic obstructive pulmonary disease. It acts on the lower airways and has no effect on the upper airway inflammation seen in Croup. It is not helpful in managing inspiratory stridor or subglottic swelling. Option B is also incorrect. Loratadine is an antihistamine used to treat allergies, but it does not reduce the inflammation or edema caused by viral Croup. It has no role in relieving respiratory distress in this scenario. Option C is not appropriate either. Aminophyllene is a bronchodilator used in lower respiratory conditions like asthma or chronic bronchitis, but it is outdated, rarely used, and ineffective in treating the upper airway obstruction characteristic of Croup. This case reinforces an important NCLEX principle, understanding the underlying pathophysiology before choosing an intervention. Croup is a viral illness that inflames the larynx, trachea, and bronchi, creating that signature barking cough, stridor, and respiratory difficulty. Racemic epinephrine offers fast, temporary relief by shrinking the swollen airway, and it is often paired with corticosteroids like dexamethasone for a longer-acting anti-inflammatory effect. Just as important, nurses must remember not to agitate children with Croup, as crying can significantly worsen the airway narrowing. A calm environment is part of the treatment. You're doing great. Let's challenge your thinking that tests your knowledge of medication education, because knowing what a drug does is just as important as knowing when and how to use it. Let's jump into the question now. Question number 4. The nurse is reinforcing medication teaching for a client who has been prescribed Guaifenesin to manage symptoms of an upper respiratory tract infection. Which client statement indicates correct understanding of the intended effect of this medication? Think about what Guaifenesin is commonly used for and how it helps during respiratory illness. It is time to examine the choices one by one. Option A. This medication will make it easier for me to cough up mucus and clear my airways. Option B. I should take this medication if I start to feel chest pain or tightness. Option C. I will use this medication to help lower my body temperature if I develop a fever. Option D. I need to avoid citrus juices while taking this medication to prevent side effects. Let us analyze these responses and figure out which one reflects a true understanding of Guaifenesin's purpose. The correct answer here is option A. This medication will make it easier for me to cough up mucus and clear my airways. This is a textbook example of what Guaifenesin is meant to do. It is classified as an expectorant. It works by increasing fluid secretion in the respiratory tract and reducing the thickness of mucus. That means it does not stop the cough. Instead, it makes the mucus less sticky and easier to bring up, helping the client clear their airways and breathe more comfortably. It is commonly used in conditions like bronchitis, colds, and other upper respiratory infections where mucus congestion is present. Option B is misleading. Chest pain or tightness can be a red flag for something more serious, like a cardiac condition, pulmonary embolism, or an asthma flare. Guaifenesin does not treat these problems, and using it for chest pain could delay critical treatment. Option C is also incorrect. Guaifenesin does not have any fever-reducing properties. If a client has a fever, medications like acetaminophen or ibuprofen would be more appropriate. Option D sounds concerning but is not based in fact. There is no known harmful interaction between Guaifenesin and citrus juices. In fact, staying hydrated with fluids, including citrus-based ones, can actually enhance the medication's effect by further thinning out the mucus. This question reinforces a common NCLEX principle, understanding the mechanism of action and therapeutic effect of medications so that nurses can confidently educate clients. Guaifenesin is widely available in many over-the-counter cold remedies and is generally well tolerated, but its benefits are maximized when paired with adequate fluid intake. It does not suppress the urge to cough. Instead, it makes the cough more productive and effective. And as always, if symptoms like fever or chest discomfort persist or worsen, clients should be advised to seek further medical evaluation, as those may indicate conditions that go beyond the scope of a simple expectorant. Let us now step into the world of neonatal care, where understanding developmental physiology and respiratory support can make a life-saving difference. Ready or not, here's the next question. Question number 5. A premature infant born at 28 weeks gestation is demonstrating signs of respiratory distress syndrome. including nasal flaring, intercostal retractions, grunting, and oxygen saturation of 89% on room air. Which medication should the nurse anticipate the provider will prescribe to improve alveolar expansion and enhance pulmonary function? Focus closely here. This is a common NCLEX topic involving both pathophysiology and treatment of neonatal respiratory compromise. Now let's review the possible answers. Option A, intramuscular dexamethasone administration. Option B, oral albuterol sulfate. Option C, poractant alpha, administered via endotracheal tube. Option D, intravenous aminophylline loading dose. Let us break this down and identify the treatment that directly targets the cause of respiratory distress syndrome in preterm infants. The correct answer here is option C, poractant alpha, administered via endotracheal tube. Poractant alpha is a surfactant, a substance that reduces surface tension within the alveoli, keeping them open during exhalation. In premature infants, especially those born before 32 weeks, type 2 pneumocytes in the lungs are often too immature to produce adequate surfactant, resulting in alveolar collapse, impaired gas exchange, and signs of respiratory distress. Administering poractant alpha directly into the lungs via endotracheal tube helps stabilize alveoli, improve oxygenation, and support breathing. This intervention is usually done shortly after birth, and studies show that it significantly improves survival and reduces the complications of neonatal respiratory distress syndrome. Now, let us review the other options and explain why they are incorrect. Option A, while dexamethasone is given to mothers before preterm delivery to help accelerate fetal lung development. Once the baby is born, it is not the first-line treatment for RDS. In fact, using postnatal dexamethasone can pose neurodevelopmental risk, and its use is typically reserved for infants who develop chronic lung disease or remain ventilator-dependent long-term. Option B, albuterol sulfate is a beta-2 agonist used to treat bronchospasm in conditions like asthma or bronchiolitis. It acts on the bronchial smooth muscle, not the alveoli, and does not help in cases of surfactant deficiency. Option D, aminophylline is a central nervous system stimulant that may be used to prevent apnea of prematurity, but it has no surfactant-related action. It does not improve lung compliance or gas exchange in RDS, so it is not useful in this situation. This question highlights a high-stakes NCLEX topic, understanding how surfactant therapy supports alveolar stability in premature infants. Neonatal respiratory distress syndrome is caused by immature lungs that lack adequate surfactant, and the administration of synthetic surfactants like poractant alpha is a critical intervention. These medications are delivered directly into the lungs and begin working almost immediately to reduce alveolar collapse, improve oxygenation, and support life during those vulnerable first hours. Knowing the difference between preventive treatments like antenatal steroids and therapeutic interventions after birth is essential for any nurse working with newborns. And it is exactly the kind of clinical knowledge the NCLEX is designed to assess. Quick pause before we jump into the question, are you NCLEX ready? If not, the Complete NCLEX Review online course gives you everything you need. 100 hours of animations, 500 hours of recorded lectures, 5,000 top-rated questions, 500 NGN case-based study, and 15 CAT-style mock exams. It also comes with a detailed NCLEX ebook. All yours for an entire year. Limited time offer. Get 70% off today. Thousands have passed. Now it's your turn. Visit our website using the link below. Here comes another practice booster on pediatric case that focuses on medication education for asthma management, a vital topic for both exam success and real-world safety. Let the question speak for itself. Question number 6. The nurse is educating the parents of a 10-year-old child who has been prescribed Albuterol as part of asthma maintenance therapy. Which parent statement demonstrates accurate understanding of the potential side effects associated with this medication? Think about how long-acting bronchodilators work and the key teaching points that go along with them. Let's walk through the options together. Option A. I understand that this medication might keep my child awake at night. Option B. I will make sure my child takes this medication only during allergy season. Option C. This medication works quickly to stop my child's wheezing during an asthma attack. Option D. I'll remind my child to use this inhaler only when shortness of breath starts. Let us now break down the best response based on accurate pharmacological understanding. The correct answer here is option A. I understand that this medication might keep my child awake at night. Formoterol is a long-acting beta-2 adrenergic agonist, or LABA, used for daily maintenance of asthma symptoms. It stimulates the sympathetic nervous system, which can cause common side effects such as insomnia, jitteriness, and restlessness, especially in children. Acknowledging this potential for sleep disruption indicates that the parent understands the typical response to the medication and is prepared to monitor for it at home. Now, let us examine the incorrect responses. Option B is inaccurate because formoterol is not meant to be used only during allergy season. It is a maintenance medication that should be taken consistently year-round to control airway inflammation and prevent asthma exacerbations. Skipping doses during non-allergy months can lead to poorly controlled asthma and increased emergency interventions. Option C is incorrect because although formoterol has a relatively quick onset compared to other LABAs, it is not considered a rescue inhaler. It is not appropriate for treating acute asthma attacks, and using it in that way may delay necessary treatment with a short-acting beta agonist like albuterol. Option D is also incorrect since formoterol is not designed for as-needed use. It is scheduled, not situational, and must be taken regularly to provide effective long-term control of asthma symptoms. Waiting for shortness of breath before using it would compromise its preventive function and could put the child at greater risk during acute flare-ups. This question highlights a core NCLEX principle: the importance of educating caregivers about proper use and expectations of maintenance medications. Long-acting beta agonists like formoterol must be used consistently and never as a replacement for a rescue inhaler. Nurses must help families understand the differences between daily maintenance therapy and emergency treatment to prevent misuse and ensure optimal asthma control. Being aware of side effects like insomnia is also important for supporting adherence and planning medication timing appropriately. With a strong grasp on these teaching points, nurses play a key role in improving outcomes for pediatric clients with asthma. Let us now turn our attention to a follow-up evaluation scenario. The kind of question that checks whether you truly understand what improvement looks like when a medication is doing its job. This one's going to test your judgment. Here it is. Question number 7. A client with a productive cough is prescribed Guaifenesin as part of treatment for an upper respiratory infection. During a follow-up assessment, which finding best indicates that the medication is achieving its intended therapeutic effect? Take a moment to think about the mechanism of action behind Guaifenesin and what specific outcomes you would expect to see. Here are the choices. Let's analyze them. Option A, client reports reduced coughing episodes and improved sleep. Option B, client notes that the mucus is thinner and easier to expectorate. Option C, client reports increased sneezing and nasal drainage. Option D, client notes a significant reduction in eye irritation and congestion. Now let us determine which response best matches the purpose of prescribing Guaifenesin. The correct answer here is option B. Client notes that the mucus is thinner and easier to expectorate. This directly reflects the intended therapeutic action of Guaifenesin. As an expectorant, its role is not to stop the cough but to make coughing more effective. It does so by reducing the viscosity of mucus in the respiratory tract, making secretions thinner, looser, and easier to clear from the lungs. That improved mucus clearance helps the client breathe more easily and recover faster from the infection. Now let us explore the remaining options and understand why they are not the best indicators of Guaifenesin's success. Option A might sound like a good sign at first glance, but reduced coughing and better sleep are actually outcomes associated with antitussives, medications like dextromethorphan or benzonatate that suppress the cough reflex. Guaifenesin does not work that way. It promotes a more productive cough rather than reducing the urge to cough. Option C is misleading because increased sneezing and nasal drainage are typically seen in allergic rhinitis or with histamine release. Guaifenesin is not an antihistamine or a decongestant, so these effects are unrelated to its mechanism. Option D refers to symptoms like eye irritation and congestion, which are usually managed by antihistamines such as loratadine or diphenhydramine. Guaifenesin does not treat eye symptoms and has no antihistamine properties. This question is a strong example of a common NCLEX strategy, asking you to match a medication's therapeutic goal with a client's actual outcome. Guaifenesin is often found in over-the-counter cold medications and is most effective when the client stays well hydrated. Since fluids help thin out mucus even more, it is important for nurses to teach clients that the goal of this drug is not to stop the cough, but to make coughing more productive by loosening the mucus that clogs the airways. So when a client says it is easier to bring up phlegm, that is your green light that the medication is working just as intended. Ready for another core concept? Let us now move into a pulmonary care scenario that tests your understanding of mucolytic therapy, especially important in conditions like cystic fibrosis, where secretion management can be life-saving. Let's see how you do on this one. Here comes the question number 8. A client with cystic fibrosis presents with severe airway obstruction due to thick, inspissated respiratory secretions. The provider prescribes inhaled acetylcysteine. Which of the following best describes the intended therapeutic action of this medication in this clinical scenario? This is a high-yield pharmacology question that calls for a clear understanding of drug mechanisms. Let's explore what each option is telling us. Option A, improvement of mucociliary clearance through breakdown of mucus viscosity. Option B, direct stimulation of beta-2 receptors to relieve bronchospasm. Option C, suppression of histamine-mediated airway edema. Option D, neutralization of airway pH to reduce tissue irritation. Now let us analyze what acetylcysteine is truly designed to do in this respiratory context. The correct answer here is option A, improvement of mucociliary clearance through breakdown of mucus viscosity. Acetylcysteine is a mucolytic, and in this inhaled form, it targets thick respiratory secretions by disrupting the disulfide bonds within mucoproteins. This chemical action reduces the stickiness and thickness of mucus, allowing the cilia in the airways to move the mucus more efficiently and making it easier for the client to cough it up. In clients with cystic fibrosis, who frequently suffer from severely thick mucus that clogs the airways, this mechanism directly supports airway clearance and improves respiratory status. Let us now rule out the incorrect options and understand why they do not apply here. Option B refers to beta-2 receptor stimulation, which is the mechanism of action for bronchodilators like Albuterol. These medications are used to relieve bronchospasm by relaxing smooth muscle in the airways, but acetylcysteine does not work this way and should not be considered a bronchodilator. Option C talks about suppression of histamine-mediated airway edema, which describes the action of antihistamines or corticosteroids. While airway inflammation may be present in cystic fibrosis, acetylcysteine does not address inflammation directly. Its role is purely mechanical, aimed at thinning the mucus. Option D mentions neutralizing airway pH to reduce tissue irritation, which is not what acetylcysteine does in this setting. Although it does have antioxidant properties systemically, particularly in cases like acetaminophen overdose, when inhaled it acts solely on mucus composition and does not alter pH or serve as a buffer. This question highlights a key NCLEX concept, linking a medication's mechanism to the client's specific clinical problem. In this case, the problem is thick, obstructive mucus, and the correct solution is a mucolytic like acetylcysteine that can chemically break down the mucus and improve clearance. Nurses should also remember that acetylcysteine can have a strong sulfur odor, often compared to rotten eggs, and that it may cause bronchospasm in some clients. For that reason, it is typically administered after a bronchodilator to open the airways and minimize the risk of airway irritation. Always monitor the client's respiratory status during and after treatment, noting changes in breath sounds, effort, and the ability to clear secretions. Understanding how medications like this support airway management in chronic pulmonary conditions is essential for safe and effective nursing care. Let us now dive into a pharmacology question that focuses on client safety and adverse effect recognition, a core part of what the NCLEX aims to test. Here's your next chance to think like a nurse. Here is your question number 9. The nurse is assessing a client who recently began taking Montelukast for long-term asthma management. Which client-reported symptom would most warrant immediate provider notification due to a potential adverse effect of the medication? As you think through this one, remember that understanding serious but less common medication reactions can make a critical difference in nursing care. Take a look at the answer options and think carefully. Option A, mild epigastric discomfort after meals. Option B, dry mouth and slight dizziness in the morning. Option C, muscle cramps in the lower extremities. Option D, visual hallucinations and increased agitation. Let us carefully consider which of these reported symptoms is most concerning and requires urgent follow-up. The correct answer here is option D, visual hallucinations and increased agitation. Montelukast, which is a leukotriene receptor antagonist, is widely used for long-term control of asthma and is usually well tolerated. However, it carries a serious black box warning due to the potential for severe neuropsychiatric side effects. These include hallucinations, increased agitation, aggression, anxiety, insomnia, depression, and even suicidal ideation. These symptoms can occur at any point during therapy, even in clients with no history of psychiatric illness, and must be reported immediately. Early recognition and intervention can prevent further deterioration and guide the provider to either adjust the dose or discontinue the medication altogether. Now, let us examine the incorrect responses to understand why they do not demand immediate concern. Option A mentions mild epigastric discomfort after meals, which is a relatively minor and often transient side effect of many medications. While it may be uncomfortable, it does not signal a dangerous reaction and typically does not require discontinuing Montelukast. Option B refers to dry mouth and slight dizziness, which are nonspecific and may result from various causes, such as other medications or mild dehydration. Montelukast is not known to cause anticholinergic effects or central nervous system depression that would explain these symptoms directly. Option C involves muscle cramps in the legs, which are not linked to Montelukast use. This side effect is more likely related to issues like electrolyte imbalance or dehydration and should prompt basic nursing assessment, but not emergency action regarding this medication. This question emphasizes one of the NCLEX's most important themes: early detection of serious adverse drug effects. Montelukast is often given daily for asthma control or to prevent exercise-induced bronchospasm. But clients and caregivers need to be educated on the risk of mood changes, especially in children and adolescents. It is not a rescue inhaler and does not offer immediate symptom relief, so it must be used as prescribed for maintenance, not in acute situations. As nurses, we must stay alert for subtle but serious symptoms like agitation or hallucinations that can escalate if overlooked. Responding promptly to these changes not only protects the client's mental and emotional well-being, but also reinforces the critical role nurses play in safe medication management. Here's another scenario that might look familiar on exam day, which is focused on a medication safety scenario involving a high-risk drug often used in respiratory care, and how age-related factors can influence toxicity. And we are live with the question. Question number 10. An 80-year-old client with a history of chronic asthma is prescribed Theophylline as part of maintenance therapy. Prior to administering the next scheduled dose, which of the following assessments should the nurse prioritize to monitor for early signs of drug toxicity? This is one of those questions where clinical reasoning and prioritization come into play, especially with an elderly population. Let's dive into the choices and see what makes sense. Option A, cardiac rhythm and heart rate. Option B, bowel sounds and gastrointestinal motility. Option C, skin turgor and capillary refill. Option D, oxygen saturation and respiratory rate. Now let us determine which of these assessments provides the most immediate clue to potential Theophylline toxicity. The correct answer here is option A, cardiac rhythm and heart rate. Theophylline has a notoriously narrow therapeutic index, meaning the difference between a therapeutic and toxic dose is small. Even a slight increase in serum levels can trigger dangerous side effects, especially in older adults whose metabolism and drug clearance may be slowed. Early signs of toxicity frequently involve the cardiovascular system, including tachyarrhythmias, palpitations, and irregular pulse patterns, making cardiac monitoring a top priority before giving the next dose. Nurses must be alert for any change in heart rate or rhythm, particularly in older clients, where the consequences can escalate quickly. Let us now examine the incorrect options to understand why they are not the priority here. Option B refers to bowel sounds and gastrointestinal motility. While nausea, vomiting, and abdominal discomfort can be early symptoms of Theophylline toxicity, they are nonspecific and less critical than cardiac symptoms when it comes to identifying and acting on a potential toxic event. Option C, skin turgor and capillary refill, assesses hydration and peripheral perfusion. Although dehydration can elevate serum drug levels, these signs are indirect and not specific indicators of Theophylline toxicity. Option D, oxygen saturation and respiratory rate, are definitely important in any client with chronic asthma, but they do not serve as early indicators of Theophylline overdose. respiratory compromise is not the primary danger in the early stages of toxicity. Instead, the cardiovascular and central nervous systems are affected first. This question highlights a classic NCLEX principle: knowing how to recognize early warning signs of medication toxicity, especially in vulnerable populations like older adults. Theophylline's therapeutic range is generally between 10 to 20 micrograms per milliliter, but toxicity can occur even within that window depending on the client's age, renal and hepatic function, and concurrent medications. Always assess for pulse irregularities, central nervous system changes, or gastrointestinal symptoms, and if there is any suspicion of toxicity, withhold the dose and notify the provider immediately. A serum theophylline level may be ordered to confirm your clinical judgment. Safe nursing practice begins with keen observation, and with high-alert drugs like theophylline, that vigilance can truly be life-saving. Hold up. Are you feeling confident about the NCLEX? If not, you'll want to check out the Complete NCLEX Review online course. It's packed with 100 hours of animated videos, 500 hours of deep content, 5,000 practice questions, 500 NGN-style case study, and 15 full mock exams. There's also a full NCLEX ebook included, with a 1-year access window. And right now, it's available for 70% off, but only for a short time. Click the link in the description and join the thousands of students who've already passed. Let us move into a question that highlights the pharmacologic management of chronic obstructive pulmonary disease, one of the most tested areas on the NCLEX when it comes to respiratory medications. Cue the clinical thinking, here it comes. Question number 11. The nurse is evaluating the response of a client with chronic obstructive pulmonary disease who has been prescribed ipratropium bromide inhalation therapy. Which of the following reflects the primary therapeutic outcome of this medication? As you consider this question, focus on how ipratropium actually works at the receptor level and what that means for the client's breathing. Now, let's evaluate each option with clinical reasoning. Option A, inhibition of leukotriene-induced airway constriction. Option B, vasodilation of coronary arteries to improve oxygen delivery. Option C, suppression of histamine released to reduce allergic symptoms. Option D, relaxation of bronchial smooth muscle to promote airway patency. Now let us determine which one of these directly reflects the goal of using ipratropium bromide in a client with chronic obstructive pulmonary disease. The correct answer here is option D, relaxation of bronchial smooth muscle to promote airway patency. Ipratropium bromide is a short-acting anticholinergic bronchodilator. It works by blocking muscarinic receptors in the airway smooth muscle, which reduces cholinergic stimulation and prevents bronchoconstriction. This action leads to bronchodilation, opening up the airways, improving airflow, and making breathing easier for clients with chronic obstructive pulmonary disease. That improved airway patency is exactly what we want to see as a therapeutic outcome. Now, let us look at the other options to understand why they are not accurate in this context. Option A describes the action of leukotriene receptor antagonists such as Montelukast, which are more commonly used for allergic asthma. Ipratropium has no effect on leukotriene-mediated pathways. Option B refers to vasodilation of the coronary arteries, which is not relevant to ipratropium at all. That mechanism is associated with cardiovascular medications like nitroglycerin or calcium channel blockers. Ipratropium does not affect coronary circulation. Option C involves suppression of histamine release, a function associated with antihistamines like diphenhydramine or mast cell stabilizers. Ipratropium does not target histamine and is not used for allergic reactions. This question reinforces a vital NCLEX concept: knowing the mechanism of action behind commonly used inhaled medications and what outcomes to assess for after administration. Ipratropium is particularly useful in treating bronchospasm related to chronic obstructive pulmonary disease and is often used in combination with short-acting beta agonists like albuterol to provide even better bronchodilation. After administering ipratropium, the nurse should assess for decreased wheezing, easier breathing, and improved oxygen saturation, all signs that the medication is working effectively. Also, be aware of potential side effects such as dry mouth, cough, or blurred vision, especially in elderly clients. Understanding how to evaluate medication effectiveness based on mechanism and outcome is key to safe, evidence-based nursing care. Time to level up again with a patient safety scenario that emphasizes responsible medication use, something the NCLEX prioritizes heavily, especially when it comes to client education and discharge planning. Let's fire up your brain. This is the question number 12. A client newly prescribed Tiotropium bromide inhalation capsules for chronic obstructive pulmonary disease is receiving discharge instructions. Which client action would indicate a significant safety concern requiring immediate intervention by the nurse? Think carefully here. It is not just about how the medication works, but also how it is handled, stored, and respected as a prescription-only therapy. Here come the possible answers. Stay sharp. Option A, offering a capsule to a neighbor who also uses an inhaler for breathing issues. Option B, storing the capsules in their sealed blister packaging at room temperature. Option C, using the medication while seated upright in a well-ventilated room. Option D, discarding unused capsules in the household trash after verifying expiration. Let us examine which action reflects a serious breach of safety that calls for immediate nursing intervention. The correct answer here is option A, offering a capsule to a neighbor who also uses an inhaler for breathing issues. This is a major red flag. Prescription medications, including tiotropium, must never be shared under any circumstance, even if the other person has similar symptoms or conditions. Sharing medications can result in incorrect dosing, unmonitored side effects, allergic reactions, or harmful drug interactions. It also raises legal and ethical concerns and reflects a dangerous misunderstanding of the importance of individualized treatment plans. Now let us quickly consider the other options and why they are not concerns. Option B describes appropriate storage. Tiotropium capsules should remain in their original blister packs until use and be stored at room temperature in a dry place to protect them from moisture and degradation. Option C also reflects good practice. Sitting upright and using the medication in a well-ventilated space promotes effective inhalation of the dry powder and helps deliver the drug into the lungs. Option D may not be ideal since medication take-back programs are preferred for disposal, but discarding expired capsules in household trash is considered acceptable as long as precautions are taken to keep them away from children and pets. This question highlights a central NCLEX concept: client education on medication safety. Tiotropium is a long-acting anticholinergic bronchodilator used once daily with a handy inhaler device for the maintenance treatment of chronic obstructive pulmonary disease. It is essential to emphasize that the capsules are for inhalation only, not to be swallowed, and that medication sharing is strictly prohibited. Nurses play a crucial role in correcting these misunderstandings during discharge education to ensure clients use their medications safely, effectively, and legally. Educating patients on safe use, proper storage, and clear boundaries for prescription drugs is just as important as teaching how the drug works, especially when clients are transitioning home with new therapies. Let us now shift into the realm of critical care, where understanding prophylactic interventions is essential for preventing complications in clients who are mechanically ventilated. Now, take a look at this one. Question number 13. A critically ill client has been placed on mechanical ventilation for respiratory failure. To reduce the risk of complications associated with prolonged intubation, which of the following prescriptions should the nurse anticipate from the healthcare provider? This question highlights the importance of anticipating the needs of high-risk clients and taking proactive measures. Let's weigh the choices and see which stands out. Option A, levetiracetam. Option B, clopidogrel. Option C, pantoprazole. Option D, tamsulosin. Let us identify which of these interventions aligns with evidence-based protocols in the intensive care setting. The correct answer here is option C, pantoprazole. Pantoprazole is a proton pump inhibitor that plays a vital role in stress ulcer prophylaxis. Critically ill clients, especially those who are intubated or on mechanical ventilation, are at heightened risk for stress-related mucosal disease due to physiological stress, decreased gastric mucosal blood flow, and hypersecretion of gastric acid. This combination can lead to the development of gastrointestinal ulcers and potentially life-threatening bleeding. Administering a proton pump inhibitor, such as pantoprazole, helps protect the gastric lining by reducing acid production, making it a standard part of intensive care protocols for clients requiring prolonged intubation. Now, let us go over why the other options are not appropriate in this scenario. Option A, levetiracetam, is an anti-epileptic medication used to prevent or control seizures. Unless the client has a coexisting seizure disorder, there is no indication for levetiracetam in a ventilated client without neurologic involvement. Option B, clopidogrel, is an antiplatelet medication used for preventing thrombotic events in clients with coronary artery disease or recent stroke. While valuable in cardiovascular care, it is inappropriate here and may even increase the risk of gastrointestinal bleeding, a complication we are specifically trying to avoid in critically ill, ventilated clients. Option D, tamsulosin, is an alpha-adrenergic blocker used to manage benign prostatic hyperplasia. It improves urinary flow in male clients with enlarged prostates, but it serves no role in preventing complications of mechanical ventilation or managing critical illness. This question illustrates a fundamental NCLEX concept, recognizing preventive strategies in high-risk clients. When a client is placed on mechanical ventilation, the nursing team must think ahead about potential complications, including ventilator-associated pneumonia, immobility-related conditions, and stress ulcer development. Proton pump inhibitors such as pantoprazole are commonly prescribed to protect the gastric mucosa and prevent hemorrhagic complications associated with stress-related ulcers. Nurses play an essential role in monitoring for signs of gastrointestinal bleeding, such as dark tarry stools, coffee ground vomit, or an unexplained drop in hemoglobin levels. At the same time, we must also be aware that proton pump inhibitors may slightly increase the risk of ventilator-associated pneumonia, so continued respiratory monitoring is crucial. Being prepared to anticipate provider prescriptions and monitor for both therapeutic effects and potential risks is a cornerstone of safe and effective nursing care in the intensive care setting. Before we begin, here's a quick question. How ready are you for the NCLEX? If you need a complete prep system, we've got it. 100 hours of animations, 500 hours of lectures, 5,000 NCLEX questions, 500 NGN case studies, and 15 exam simulations, plus a powerful ebook. You get all this for a whole year. Best part? You can enroll now for 70% off, limited time only. Head to the link in the description and let your NCLEX journey begin. Stay focused. Here's your next high-yield checkpoint focused on long-term management of chronic obstructive pulmonary disease, a key NCLEX topic, especially when it comes to client education about inhaled medications. All right, bring your focus. Here comes the question number 14. A client with chronic obstructive pulmonary disease is prescribed tiotropium bromide inhalation therapy for long-term symptom control. During a follow-up visit, which client statement would indicate correct understanding of the proper use and dosing of this medication? As you evaluate the options, focus on which statement reflects safe, effective, and evidence-based use of this maintenance therapy. Let's go through the answer choices like a nurse would. Option A. I take this medication once every morning to help keep my breathing stable throughout the day. Option B. If I start having difficulty breathing, I can take an extra dose of this inhaler to relieve it. Option C. I store the inhaler in the refrigerator to make it last longer. Option D. I always spray the inhaler into the air once before each use to make sure it's working. Now let us break this down to identify the response that demonstrates proper understanding. The correct answer here is option A. I take this medication once every morning to help keep my breathing stable throughout the day. Tiotropium is a long-acting anticholinergic bronchodilator designed for once-daily use to maintain bronchodilation and reduce symptoms in clients with chronic obstructive pulmonary disease. Consistent use at the same time each day helps maintain stable lung function and prevents symptom flare-ups. Educating clients on this fixed routine is essential, as missing doses can lead to worsening control and increased exacerbations. Let us now review the incorrect responses and explain why they reflect misunderstanding or unsafe practice. Option B is concerning because tiotropium is not a rescue medication. Taking an extra dose to relieve sudden shortness of breath can lead to anticholinergic side effects, such as dry mouth, blurred vision, urinary retention, or elevated heart rate. Rescue symptoms should be treated with a short-acting beta agonist, such as albuterol, not by increasing the dose of a maintenance inhaler. Option C demonstrates incorrect storage. Tiotropium should be kept at room temperature and away from heat or moisture. Storing it in the refrigerator may compromise the medication's integrity or interfere with proper dosing, especially if using a device such as a HandyHaler or Respimat. Option D reflects a misunderstanding of priming. While some inhalers require initial priming before first use, or after several days without use, daily priming before every dose is unnecessary and wastes medication. Clients should be taught to follow the device-specific instructions and to avoid priming unless directed by the product guidelines. This question reinforces a crucial NCLEX principle, that nurses must educate clients not just on what to take, but on how to take it safely, when to take it, and what to do if symptoms worsen. Tiotropium bromide provides 24-hour bronchodilation by blocking muscarinic receptors in the airway, and it is a cornerstone of maintenance therapy in chronic obstructive pulmonary disease. Clients should be taught proper inhalation technique, the importance of consistent daily use, and the distinction between maintenance and rescue medications. Monitoring for side effects such as dry mouth or urinary retention is also part of the nurse's role in follow-up care. Ultimately, client safety and treatment success hinge on clear, accurate education about both the medication and its proper use. This next one could make or break your test. Let us now tackle a question that zeroes in on medication interactions, a crucial area of safety in respiratory care and a favorite topic on the NCLEX. Okay, future nurse, here is your next challenge. Question number 15. A client with chronic asthma has recently been started on Albuterol, a long-acting beta-2 agonist, as part of maintenance therapy. Upon reviewing the client's current medication list, which concurrent prescription would prompt the nurse to immediately notify the primary healthcare provider? This question tests your ability to spot dangerous pharmacologic conflicts before they lead to complications. Each option tells a story. Let's break it down. Option A, sertraline. Option B, labetalol. Option C, captopril. Option D, clonidine. Now let us determine which medication listed could directly interfere with the action of Albuterol and place the client at risk. The correct answer here is option B, labetalol. Labetalol is a non-selective beta-adrenergic blocker that affects both beta-1 and beta-2 receptors. Because Albuterol works by stimulating beta-2 receptors in the lungs to promote bronchodilation, labetalol essentially blocks that effect. This can lead to bronchospasm, decreased airway opening, and a potentially life-threatening reduction in respiratory function, particularly in clients with chronic asthma or other reactive airway diseases. For this reason, the nurse must notify the primary healthcare provider immediately if labetalol is prescribed concurrently with a beta-2 agonist. Now, let us look at the other options and clarify why they are not of immediate concern. Option A, sertraline, is a selective serotonin reuptake inhibitor, commonly prescribed for depression and anxiety. It does not interact with beta-2 adrenergic receptors and poses no risk to the bronchodilatory effect of Albuterol. Option C, captopril, is an angiotensin-converting enzyme inhibitor used to treat hypertension and heart failure. While it may cause a persistent cough in some clients, that effect is unrelated to airway obstruction or beta-agonist activity. It does not interfere with the action of Albuterol. Option D, clonidine, is an alpha-2 adrenergic agonist that acts centrally to lower blood pressure by reducing sympathetic outflow. It does not block peripheral beta receptors and therefore does not counteract Albuterol's bronchodilatory effects. This question reinforces a core NCLEX nursing principle. Always be alert to pharmacologic conflicts, especially when it comes to medications that influence respiratory function. Albuterol is a long-acting beta-2 agonist that is used regularly as part of maintenance therapy in asthma and chronic obstructive pulmonary disease to keep the airways open and prevent bronchospasm. However, combining it with a beta blocker like labetalol undermines its therapeutic action and puts the client at risk for respiratory compromise. Nurses must be proactive in reviewing medication lists, recognizing harmful interactions, and notifying the healthcare provider promptly when something could jeopardize the client's safety. And thanks for staying with us through today's deep dive into pharmacology of respiratory. We hope it helped make these complex topics a whole lot easier to understand and apply. Remember, success on the NCLEX comes from consistent exposure to the right topics, and that is exactly what we bring you every single day. We will be back again soon with another high-yield video, packed with the critical concepts and exam-style questions that matter most. So do not miss out. Keep watching, stay consistent, and follow us for daily NCLEX content that can truly make the difference between struggling and passing with confidence. This journey to becoming a nurse is tough, but with the right guidance and daily practice, you are absolutely going to make it. Stay focused, and we will see you in the next video.